Okay. Thank you, PCSI, for this opportunity to let me speak on a subject that I'm extremely passionate about. So we're talking about virtual reality in pediatric cardiac sciences, hype or hope for the future. I'm a pediatric cardiologist. I'm not an engineer, but I like playing with tech. I use a lot of commercially available as well as beta research versions of 3D imaging softwares from different vendors, being an early adopter of technology, but I have no commercial relationships with any of the vendors. So there are no financial disclosures. First of all, I pay my homage to our teachers, our legendary teachers who will continue to inspire many, many generations to come. So virtual reality, what is virtual reality after all? So virtual reality is a computer-generated simulation of a three-dimensional image or environment that allows you an immersive interaction in a seemingly real or physical way. It's actually tricking your brain into thinking that this environment is real. It feels so real. And this is achieved using specific or special electronic equipment. For a broader background, just talking about 3D plus technologies. What is 3D plus technologies? These are various new technologies that allow us to interact with 3D digital data in an immersive fashion. This digital data could be anything. It could be something that somebody has designed on a computer. It could also be medical imaging data, which is actually 3D digital data. And the 3D plus technologies range from 3D printing to now virtual reality, augmented reality, mixed realities, or in a broad bracket, we call them the extended reality visualization platforms. And over the past few years, it's, ironically, it is kids who are, involved in gaming that have led to a tremendous development of these technologies. You see kids with, gaming headsets on. And that has really spurred a lot of development, making this technology inexpensive, cheap, and easily accessible. And so we have the opportunity to actually dig into these technologies. That's all fine, but what's this got to do with pediatric cardiac sciences, right? Because we are not kids or young teenagers, excitable teenagers, playing funny games, wearing funny headsets. Neither are we cyberpunks playing some sci-fi games. We are very serious men and women of science with the onerous responsibility of taking care of people with heart disease. And we have spent our lifetimes reading hundreds of books and learning hundreds of classifications and nomenclatures of various kinds of heart diseases. And we are also extremely good at making three-dimensional sense out of two-dimensional pictures, be it looking at echocardiograms, where you look at two-dimensional slices and reconfigure that in our minds, or we look at surgical diagrams and we configure all that in our minds. We are extremely good with that, or are we? There is a paradox. We are living in a three-dimensional world. Our human eyes see the world through a stereoscopic vision. And much of our specialty is spatial. Think of all the morphological complexities that you see every day. And our operating fields are all three-dimensional. Yet, much of our learning, communicating, planning, decision-making, etc., is all based on reading information or viewing things in pure two dimensions and reconfiguring things in 3D in our own heads. Most trainees in our specialties never ever get exposed to morphological specimens. This cerebral processing actually depends upon two vital and highly variable elements, converting 2D information to 3D. First, visual processing skills. This is a very individual skill. It's the ability to perceive, analyze, synthesize, and think with visual patterns and store and recall visual representations. And it actually is made up of multiple small components, including visualization, speed rotation, spatial scanning, etc., etc. Second, experience. Obviously, when we have seen something, we've done something, we know it. But experience is something that takes years and years to achieve. Not only that, no one on this earth can have experience of all kinds. No cardiologist or cardiac surgeon has seen every single complex morphology that's been there. It's almost like, coming to Calcutta after having read a book about Calcutta and trying to imagine what the chaos in Calcutta is all about. That's what we are doing when we're looking at complex reports of CT, MRI, echo, etc., and imagining what the author is trying to say. When you see a picture of Calcutta, yeah, it begins to strike you. Okay, this is what Calcutta is about. That's what we do when we look at images of echo, CT, etc. We begin to, imagine, this is how it looks like. But you've got to be here in Calcutta, in flesh and blood, to actually realize what it's all about, the sense, and have the sights and sounds and smells. And that's the kind of perception that a surgeon gets when he sees the cardiac morphology in true blue 3 dimensions, or the lucky people get to see a morphological specimen. There's been some work on trying to understand how spatial understanding affects people in medicine, and people have studied medical students in their early career and correlated anatomical understanding with spatial ability and their ability to acquire surgical skills. So the better spatial ability you have, the more likely you are to be good at anatomy and acquiring surgical skill. This also translates to imaging skills. This is, of course, offset a little by the practice and hands-on surgical experience that people gain later. So we tried an experiment where we gave a very objective and validated spatial visualization test called the revised Purdue Spatial Visualization Test of Rotations to a bunch of my cardiology colleagues and cardiac surgeons, just to see what's the range of spatial understanding. So this involves 30 questions having little objects in 3 dimensions, and they're rotated, and you're supposed to predict what the object would look like if it's rotated. And interestingly, everybody's performance was very scattered. The performance was ranged from 0 to 17 out of 30 answered in that in that 20-minute interval, which basically goes on to show that people have different ranges of spatial abilities and understanding. The conventional way of visualizing medical imaging data for us is looking at these 2D screens, where we look at echo, where we look at cath, and even the volumetric 3D images are visualized on 2-dimensional screens. This is the way you would look at a CT in tomography. You can do some 3D rendering, but you look at 3D rendering, even then you need some kind of rotation, movement to actually give you a sense of depth perception. Can we leverage the 3D plus technologies in medicine? That is the question we're trying to address here. Yes, today we are doing that. 3D plus visualization of volumetric medical imaging data. This is not a new modality of imaging. It's just the way that you're visualizing this data. It could be 3D printing. So you have a life-size article, which is an exact replica of the cardiac morphology in your hand. Or you could have extended reality visualization. And under extended reality visualization, there is virtual reality, there is augmented reality, and there is mixed reality. You'll get to see that a little more as we go on. The workflow for all of this is the same. Everything starts with imaging, acquiring good CT and MRI or 3D echo data sets, which are basically stacks of information. This is processed or segmented on workstations with specialized software and converted into a model that can either be 3D printed out into a physical prototype, or the same digital file, you can bring it into a platform that can be visualized in virtual reality. This is the way the segmentation process happens. This is using the Mimics Innovation Suite software, where this is an MRI scan, which you're looking at in 2 dimensions, and then you're carefully segmenting out your region of interest, which is the heart, converting that into a 3-dimensional model. And this model can then either be printed out physically or be brought out into a virtual reality visualization environment. While a 3-dimensional model is a fixed structure, in virtual reality, you can actually have infinite opportunity to dissect through multiple planes flexibly in whichever way you would want. And this is the way that we would do it. You put on a headset, and then you are ready to immerse yourself into the world of virtual reality. You draw out the model, and it's not like the 2-dimensional model that you're seeing out here. For the wearer of the headset, it is a full 3-dimensional structure hanging in front of you, and you can actually bury your head inside, walk inside the heart, take a look inside, come out, dissect in multiple planes, whichever way you want to look at it, and get a deeper sense of the anatomy. And it's almost like handling a real physical object. So if you created your 3D model in multiple parts, you'd be able to handle each of them, move them around using these things that you call as the game controllers. These are things that are supposed to be used like triggers for the games. You can use the same thing to handle these multiple parts of the 3D models. But then how and where would this be useful? This, at our own hospital, it's now become part of our own clinical workflow, that we use it to solve complex cases, to understand complex morphology, to address study questions that have not been adequately answered by conventional imaging or by conventional visualization of imaging. And we all know that outcomes hinge on our ability to plan our procedures very well. The better planned we are, the more confident that we are of giving a good outcome to the patient. This is an example of a case where post-echo also, there were a lot of questions that were unanswered. It was a double outlet right ventricle. On the echo, there was evidence of some mitral valve straddling. And the patient underwent a CT scan, and this is the 3D reconstruction of the CT scan, and the heart has been converted into a hollow model, and we are able to look inside. You can see the mitral valve leaflets, you can see the papillary muscle, you can see the straddling of the mitral valve across into the right ventricle. The plane of the VSD is far away over there. This here is the aorta, and over here is the opening of the pulmonary artery. So you're getting a sense of what this is about, but this is still on the two-dimensional screen, but you're still able to see a lot of the structures that are there. This is a diagrammatic representation of the same lesion, where you can see the mitral valve straddling across the VSD into the LV, and the pulmonary artery is posterior to the aorta and in line with the VSD. Next, we put on the virtual reality headset, because so far you were still visualizing it on a 2D screen. But once you put on the headset, it becomes a different world altogether, because now the heart is actually hanging in front of you. It's scaled up. You can walk through it, you can dissect through it, and you can actually get a depth perception of where the papillary muscles are attached, how the VSD is in a much more posterior plane than you would expect, and how the great arteries are related to that particular VSD, and how the pulmonary artery is more likely to be routable to that VSD. Looking at this immersive kind of, having this immersive experience, the surgeons were able to decide that this lesion is best corrected by putting a VSD patch on the rightward aspect beyond the straddling of the valve, and then creating a tunnel that would direct the LV flow into the pulmonary artery, and then do an arterial switch. So this whole process was planned in the virtual reality lab, and the surgeon goes into the theater and executes that to perfection with no confusions on the operating room table. This is another complex case, and here I'm segmenting out this heart, that too in virtual reality. The whole process is happening in virtual reality, where the CT scan is there on a virtual table, and I'm using these game controllers to actually build the 3D model out of this heart. And eventually what I'm getting is I'm drawing out a real-time, real-size 3D model of the heart out of the patient's own data. And this is in full 3 dimensions right in front of me. It's as if it's right there on my table, and I'm looking at it and I can touch it. And this was a very funny anatomy. This was a very complex case where post-echo, we were not able to really figure out what was happening. Was it a crisscross heart? Was it an anatomically corrected malposition of great arteries? We weren't totally sure. So this seemed to be an interventricular groove, but there also seemed to be the LV actually crossing over to the right side. And externally, though it appeared like a double outlet right ventricle, the aorta was actually arising from a rightward outpouching of the left ventricle. And there was a long subaortic muscle tunnel, which had been pointed out in the echo as subaortic obstruction. But here now I have the opportunity to actually walk into the heart. So I put my head inside through the tricuspid valve. I'm there. I can see the VSD. I can see a big muscle bundle going across the LV. I cannot see the aortic valve. Instead, I can see this small outflow. And now I'm looking down at the apex of the left ventricle. And this small outflow is what leads to the aorta. So it is a very unusual anatomy, something that we had not really seen before. And it took some time for us to figure out. But walking in and out of the heart like this really gave a sense of what was happening. So this is the way that you can interact with medical images. The medical image is nothing else. It's the same CT scan that you regularly get done. It's just the way that we're interacting with is different. Here, I'm going to enter into the aorta. I put my head right into the aorta and go down the tunnel. And where do I end up? I end up inside the LV. I can see that muscle bundle, which I previously saw from the other side. I can look at the VSD from the LV aspect. And I'm actually doing this very physically, as if it's very real. I'm using a cut tool now to do a virtual dissection to again make sure that I'm getting the anatomy right, how the aorta is coming from. So the RV is actually, morphological RV is actually ending here. This thing which forms the apex of the heart is actually the LV, and the aorta is coming from here. And there is a long muscle tunnel below the aorta causing subaortic obstruction. Well, I thought, let me try to walk into the subaortic tunnel. So here I am walking in, crossing through the VSD. I can see that outlet into the aortic outflow. I'm going inside there, and I'll turn up and I would see the aorta. There it is. So I've gone in through that narrow outflow tract, gone into the aorta, and I'm climbing up as if I'm a mountaineer, climbing up through the aorta and really understanding that anatomy very well. So once we had figured out this anatomy, it became easy for the surgeon to understand how to do the repair. He would open up the tricuspid, he would open up the right atrium, look at the VST, go through the VST, resect the subaortic muscular septum, or the conal septum or the muscle that was in the subaortic area, and then close this VST. The RV was borderline small, so we kept a backup plan of may need a plus minus Glenn, but we managed to do it without the Glenn. But being able to plan such a complex surgery beforehand in the VR lab really helped the surgeon to go in and execute this to perfection in the shortest possible surgical time. This is a case where this is a genetically abnormal child with a fibrin-4 mutation with a massive aortic aneurysm. This particular modeling was done because we are planning an ascending aortic replacement. We wanted to get a sense of how big is the aorta with respect to the rest of the body. And you can clearly see how massive the aorta is and how the airway, which is in the yellow, is really crushed behind. And I can actually take out this heart and the aorta from this rib cage. There it goes out. And I'm looking at the airway behind in yellow. The left bronchus is completely compressed. The pink is what's left of the really collapsed left lung that's there. So this is again intended to help the surgeon plan his procedure down to a precise nature. This is a case with multiple AV malformations, pulmonary AV malformations, and this is a 3D rendering on the 2D screens. And then here, the same model in the virtual reality in full 3D, where we can not only look at these structures, we can make precise measurements for planning your interventions. And this is all happening in 3D, mind you. And it's all happening in the air. If I was to do it here, you would find me gesturing like this and making all these things in the air. Not only that, you can annotate. You can invite somebody else to put on the headset and see the same things that we have annotated. So all this can be done in this virtual space. This is again a case that we are planning for a transcatheter, possibly a closure of a sinus venosus ASD. Yet again, having a beautiful 3D rendering gives you a deep sense of the anatomy, the lie of the ASD, the length of the SVC, and being able to measure things down to precision and being able to plan a procedure down to the minutest details. That's what 3D allows you to really achieve. This is a case where we are planning a melody valve implantation, and if we wanted to see where would the melody sit, how would it sit, how much more space would be there for the conduit to be stented. And this is a simulation where we have placed a simulated melody valve in the exact location where we would want. And this gives us a very good picture before we go in as to how we are going to proceed with this particular procedure. This is a crisscross heart with superior inferior ventricles and a double outlet right ventricle. This is a situation where we've used a combination of virtual reality and a 3D printed model, because all of these are complementary. So you combine your virtual imaging, and you have in your hand a life-size model, your clarity about the anatomy becomes supremely clear. So you are much better positioned and empowered to operate upon this patient. This is one of the most craziest kind of cardiac morphologies that one can see. The heart seems to be twisted completely out of its normal orientation. You cannot see the aorta and pulmonary arteries coming off from where they should. If you look down, you can see that the great arteries are arising from a deep down in the thorax. And this is what we call a crisscross heart. So there is a complete rotation and twisting of the heart so that the great arteries are pushed way down. So it's a clockwise rotation. So the entire morphological RV has been pushed back and down, and your morphological LV has been pushed rightward and upwards. And you've taken this heart out of the chest cage, and you're able to look at this in great detail. So this is what a topsy-turvy heart looks like. And there is no better way to learn topsy-turvy heart anatomy than actually looking at it in such vivid three-dimensionality. Not only can you do this, you can actually invite somebody into a session. So this is me and my collaborator in Canada. We are both together in one session as avatars. And we are looking at the same cardiac morphology. We are pointing out things to each other. We're discussing the anatomy. We're discussing possible strategies. We are across different continents, but connected together in real time. Yesterday, I presented this in the Surgeons Forum where we looked at how virtual reality can help redo sternotomy because we deal with so many complex heart diseases undergoing redo surgeries. And many of them have got significant adhesions, and their complexity of anatomy makes it very unpredictable. What do you find behind the sternum? What are you going to injure? And here, this is our surgeon actually before a sternotomy looking at the three-dimensional model of this particular patient, because he says he always opens the sternum from below, from subxiphoid space, and then would gently dig his way in. And here he's doing the same thing, but virtually, understanding exactly what is the space between the sternum and the heart and the cardiovascular structures. Where can he go in? And he can actually put his head into the thoracic cage and look at things, understand the structures which come in close approximation to the sternum. There he goes. He puts his head right in. You can see how the aorta is in close proximity to the sternum. Gets out of this side and gets into the other side, again looks around. So once you have a clear perspective of what you're getting into, you are much better prepared and you can plan your procedure much more safely. Going one step further, now we have the Microsoft HoloLens, which is actually a mixed reality device, because with virtual reality, you shut off the rest of the world, you're only immersed in this virtual environment. Whereas with mixed reality, you have a transparent glass over your eyes. So you can see this auditorium, but you can also see the 3D object right in front of you. The power of that is, here we have actually registered the CT of a patient onto somebody's chest. And you are using a clip tool to actually look through that. So imagine doing this in the operating room while doing a sternotomy. You register the patient's own CT to the patient's chest, and then you can actually see through the patient. You know exactly what structures are behind the sternum or under the saw. So this is technology that is, really taking it to the next level, be it in the cath lab, be it in the operating room. You can have multiple people from across the world join you in a session, actually see the surgery along with you, and maybe even guide you doing this. So many of these devices like the Microsoft HoloLens have thrown open the environment for developing applications. So third-party applications are being developed where we can invent what we want. It is up to us what we want to make out of this technology, what we want to create. It's entirely up to us. So extended reality in pediatric cardiology has many roles. What I've shown you is very patient-specific volumetric imaging data related things. So you can, for diagnosis, treatment planning, surgery. And in this process, we have created a huge morphological museum, because every CT that we've converted into 3D file becomes a part of a morphological museum as a complex DORV, as a whole family of DORVs or CCTGAs or topsy-turvy hearts or crisscross hearts. So anybody from anywhere in the world can access this data, put on an inexpensive headset, and actually be able to look at these things. And these headsets are becoming very inexpensive, especially with the metaverse coming up. For 20,000-30,000 rupees, there's a headset. And if you build platforms where this knowledge can be shared, it becomes completely democratic. Also, you can create specifically graphically designed applications as teaching tools. You can create a virtual environment for teaching echo, for ultrasound, for doing procedures, for patient handling. So already many applications have come up, and we can create many, many more. So 3D extended reality visualization actually impacts the way your brain thinks, learns, and reacts, because it gives you a sense of reality. It can drastically cut down the learning curve, especially for the younger generation. I think they'll have this huge advantage of using these tools to cut down their learning curves in terms of, and also overcoming the individual differences in spatial intelligence as well as experience. Because once you have something in 3D, it becomes crystal clear to you. No matter what the classification or nomenclature is, once you have it in your hand, you know what it is. And leveraging this kind of technology can be a true game changer in medicine. And this will lead to a breaking of a lot of conventions in the way how to learn, communicate, interpret images, plan surgery, etc., etc. And the way forward is that we clinicians know what our needs are. We need to work alongside technologists in developing indigenous software, newer tools that are custom to us, discovering and developing newer use cases, and using technology to unshackle knowledge and knowledge sharing from both the physical as well as metaphysical boundaries. I'm deeply indebted to these two guys, who have been a part of my journey in these 3D plus technologies. Hari, who was actually, he is a CHD survivor and the first patient, among the first patients in India to get a 3D print assisted heart surgery. And he himself is a 3D tech enthusiast and works with me in my 3D lab. And Sarin, who passed out of his MTech last year, and just because of his passion for this, he has joined my team. And so they're completely different. They're not doctors, they're technologists and engineers, but we all work together. Thank you very much.